Hello, everyone. Hi. I would like to request everyone to be on camera for the starting few minutes. There's someone named as Wild Phoenix. Can you please rename it? You are on mute. Guys, please drop in a message to your friends and peers to join in, and we'll start maybe next 30 to 45 seconds. In the meantime, please be in a state where you can switch on your cameras. So we'll start now. Good afternoon, everyone. Thank you for giving out some time on a Monday afternoon to join the event. We know today is World NTD Day and World Leprosy Day as well. So this particular webinar is focused on NTDs and leprosy is a part of it. We'll be focusing on multiple aspects with our speakers and experts. We have with us Dr. Bhupendra Tripathi. He's currently working as country lead at Bill and Melinda Gates Foundation. And earlier he worked on measles elimination with UNICEF India. And he has spent some time in WHO as well to contribute on polio immunization program. Before starting, I'd like to introduce myself as well because it's good to know the moderator. I'm Anshika. I'm currently working with FPHS as a project associate, communications and partnerships. And I have my team members with me as well. Whomsoever names I'm taking from FPHS, please just wave your hand and say hello so everyone knows us. Going from the top side of my screen, we have Sapna. Sapna is working as a research associate.
Yeah.
Then moving on, we have
Dr. Sudhi.
Janvi is with us today from FPHS. We have Balaji as well. He's named as FPHS because he's handling it. Then we have Twinkle. Then we have Sindhuja, of course. She is the lead communications. And we have Dr. Rajiv Kumar Jain. He's a senior advisor. Nimi is there as well, but due to some, I think, technical issues, her video is not there. I would like to start this webinar with a couple of slides which I have prepared to give everyone a brief idea about what FPHS is and what we do. It'll take maximum 2 to 3 minutes to go through it. Just let me know if you guys can see my screen. Just a second. Can you all see my screen?
Yeah.
Yes, perfect. It's full screen. So here is what FPHS in a line. We at FPHS envisions accessible, affordable, and quality primary healthcare for all, covering multiple aspects of public health and working on the same. What do? We are into policy and strategy formulation, advocacy and communications. Can you wait a second?
Your slide is not visible.
Yes,
Can you see it now?
Now it is.
Now it is here.
I'll try to zoom in as much as possible. Uh, yeah, so I was talking about this one first. We at FPHS envisions accessible, affordable, and quality primary healthcare for all. We stand by it in the public health sector. Then we go to what we do. We are into policy and strategy formulation, advocacy and communication, knowledge, research and knowledge management, and then capacity building and campaigns. Thirdly, what we have done till now. Here is a key representation of couple of things we have did in the past in the last year. There were three reports we worked on and an upcoming book, which is DDESS. And then there's a picture of our team who conducted the visual storytelling workshop focusing on health communication in collaboration with vPhoto. I'll stop sharing my screen now. So in today's session, we'll go one speaker by one. First, we'll go to Dr. Tripathi, then we'll move on to Dr. Jain, and then we'll move on to Sindhuja. And in the end, there is a surprise element for all of us. So over to you, Dr. Tripathi.
Thank you, Anshika, and a very good afternoon to everyone present here. At the outset, I would like to thank the organizers for hosting this important webinar. So, Anshika, do you have any questions through which you want to move ahead, or what's your plan?
Sir, it's open to you, however you want to take it, but it will be great to have a context setting for the participants because we are not sure whether they, I mean, what level of it,
So
knowledge they are having about it.
Before I start, it will be nice to introduce Dr. Rajiv, sir, because he has joined us and perhaps we did not introduce him properly. So may I request you to please introduce Dr. Rajiv, sir? Yeah.
Yes. Moving on. So we had a brief introduction about each of our speakers as and when we move towards their session, but taking on the special request. Dr. Rajiv Kumar Jain is a senior advisor at FPHS. He is currently the director of programs, academic and research at Academy of Hospital Administration. He is an expert in the field of public health, and we'll be listening about the roadmap to eliminate NTDs from him. And of course, there'll be probing questions as well. So we would like to keep the floor open for the same.
Perfect. This is super helpful. And welcome, sir. So nice to see you. And all the colleagues from the organization and friends who have joined. So maybe, I'll take just some time and share a couple of slides so that people understand what we are talking about regarding neglected tropical diseases. And then perhaps there are some action items, linked up. I'll also share thoughts on that as well. So please let me know when you can see the slides. Is it visible?
Yes, your slides are visible. Yes.
Perfect. So, well, friends, once again, thanks for joining this webinar. I just want to, take you through an important topic, which is basically neglected tropical diseases, which has been really neglected in our country. And of late, there has been some initiatives, which we have started with, and things are coming up at the front, at the policymakers level, at the bureaucrats level. But in addition to that, what exactly this is, I'll just share my thoughts on that. So, if you can see this particular slide, there are 24 pictures from 24 countries. And there is something very common in every picture from each country. Can you just guess what is that commonality in this particular picture? Anyone? So one thing which is very clear is the socioeconomic condition of individuals. Like each of the picture is showing you that there is some problem in their living standards, they are wearing their surroundings, etc. So what happens, people living in these poor, situations, there are close to 2 billion people in the country, in various countries who are living in these areas, and most of them living in tropical, subtropical climate areas, and they are at the risk of diseases which are known as neglected tropical diseases. Now, the point here is, what is a neglected tropical disease? So let me take you through the classification of the neglected tropical diseases. And basically, these diseases can happen because of bacteria, virus, parasite, or venom. But we are not focusing on the causative organism. What we are focusing on is largely on the programmatic aspect. So in terms of neglected tropical diseases, WHO has classified these 20 odd diseases or disease conditions into categories. So for example, there are few diseases among NTDs which are due for eradication, which means, from the planet, the whole causative organism will not be there and the disease will be taken off. For example, smallpox was, done in the past and polio is on the way. Here we can see yaws and tuberculosis, Guinea worm. And you must be aware that in India, India has actually cleaned up both the diseases, yaws as well as Guinea worm. Guinea worm is only limited to one geography globally, Africa, and perhaps this year we may find that there are no human cases because of this disease. The second category is for elimination. And elimination here means that the causative organism will be present, but the disease may have not happen because the situation will be so better, like the people who are treated and there is no contact. So in this particular scenario, we have leprosy, onchocerciasis, and had human African trypanosomes. So there are a couple of geographies where we do have problems of leprosy in India, although onco and had are basically in African continent. Then there is a third category, which is elimination as a public health problem. What happens in this situation that the disease will be there, but there will be a threshold or a target below which we want to keep the disease. So there will be some number attached to that. For example, if we talk about the disease like lymphatic filariasis, we call filaria in India. So if the LF situation, which is measured either by macrofilaria rate or a filaria testing strip antigenemia rate. So if it is less than 1 as a MF, we say that you have achieved the elimination as a public health problem level. Or antigenemia, if we check, it is less than 2%. Next is visceral leishmaniasis. We also call it Kala Azar. And Kala Azar had been a big problem in India, especially in Bihar, Jharkhand, West Bengal, and eastern part of Uttar Pradesh. We also have this problem in Nepal and Bangladesh. But as of today, Bangladesh has actually reached to that level of less than 1 case per 10,000 at a sub-district level in Bangladesh. Even India, out of we had 633 blocks. Out of them, in 54 districts, only 1 block has been above the target. It's at block level. 1 or like more than 1 is the target for above the elimination threshold. So Jharkhand has only 1 block left at that level. Otherwise, the whole country has reached to elimination as a public health problem level. Then we have rabies, we have soil transmitted helminths, these are the intestinal worms, trachoma, you all know that. Then cysto, chagas, and hat is also there. Like these are for elimination as a public health problem. Then the fourth category among the NTDs comes to which are only controllable. We cannot eliminate or eradicate those diseases. And there are a couple of them. You must have heard about dengue, chikungunya, snake bite, venoming, scabies, pheniasis, mycetoma. Rest are like Borrelia ulcer, Echinococcus, foodborne trematodes, leishmania, which is cutaneous, and then various type of fungal infections. Now, there is a color coding in front of each disease. So basically what we are trying to say that if we have all the diagnostics available, all the drugs available, and the program is running very good, then we say that we are moving towards the target, which is like very green. And if we do not have diagnostics, if we do not have good treatment, if we are not reaching to the target population, in that case, it's either yellow or, brown or red. So you can see there are many diseases which are basically red or, brown or orange, whatever we call it. That means that there is a need for diagnostics or treatment for specific diseases. And mind you, neglected tropical diseases do not happen in the developed world. They are mostly in the countries which are like economically poor. So we do not have sufficient resources to develop the diagnostics or develop the treatments for these diseases. Now, having said that, what is the basic classification and about the NTDs? If you can see that what do they require? They require an environment which is tropical in nature. For example, the temperature will be high, the air will be humid, there will be some water content available in that. And these diseases do not provide immediate threat to the global community, just like what we saw in COVID. The moment COVID hit the developed nation, it became priority number 1. But these entities have been there for centuries, but they are not actually going to harm the developed nation. So perhaps that is not going to be a priority for them. then they affect the poorest of poor, poor in the sense of economically, poor in the sense of sociologically. So these populations which have high mortality, which have high stigma and discrimination, so these people actually struggle with these diseases. The good part about NTDs is that these can be controlled, prevented, and sometimes eliminated or eradicated with effective and available solutions. So the question here is that do we have right diagnostics, medicines, or tools available with us? And in the past, nobody was talking about these entities at a higher level. But you must have heard about the Millennium Development Goals, Sustainable Development Goals. So the difference between Millennium Development Goals and SDGs is that initially we had tuberculosis, malaria, and HIV as part of MDGs. But when the SDGs were designed, they added neglected tropical diseases and hepatitis in that. So now each country actually has to design indicators for NTDs because they have to report back to the United Nations. And the point in SDGs is about the health is point number 3, and 3.3.5 is basically on NTDs. So that is a very important thing. And because today is a World NTD Day, and you remember that every time there is a tagline, and the last year's tagline I'm sharing here today is like, act together and invest in NTDs is 2023 tagline. Now, moving ahead, why it is very important for India to talk about NTDs. Now, if you see, this is basically a paper which was published long back in 2016-17, and in which they had brought up all the NTDs and the approximate, India burden and the global burden. And where does India stand in terms of numbers, in terms of ranking? So if you see, among all these diseases, out of 20 odd diseases, roughly, 12, 11 or 12 diseases, India was actually on the top, which is perhaps not a good thing. Even if we have big population, why should we have all the diseases in India? China at that time had a bigger population than us, but you don't find China in any of these diseases. So that is something which we have to think seriously about, and we will have to talk about these diseases so that we are not shown as the highest contributor for these diseases. Now moving forward, I will just correlate couple of things with two diseases. And for example, if you see, this is the National Health and Family Survey 5 data regarding anemia in all the women of reproductive age group. And if you see the picture, 57% of the women population is basically anemic. And you can very well see the color coding. The darker the red color, more the problem in those areas we have. And then if you see, this is basically data about the underweight children. Again, like 1/3 of the children in our country are underweight. And if you see the color coding, it's again like a dark red is for the problem areas. The third is about the sanitary condition. So like 70% of the areas people have sanitary latrines and they are using it. But again, there are areas which people are not using it. Now, having said that, we just focus on the geography for now. I'll come to that. Now, in terms of nutritional status, if you see that stunting has not changed much from 48 to only 38% between NFHS 3 and 4, that has been there, same for underweight. And if you see the situation of nutrition among the children, you will find that, the more the poorer the population, the more, malnutrition is there. The last, bar graph over here. Now, why am I telling all these things to all of you? Basically what I'm trying to say is that there is a very nice opportunity where we are getting something done for the country, where at least we can focus on at least couple of entities. I'm not going to speak much about Kala Azar here, but I'm just letting you know India is achieving progress, and perhaps this year all the blocks will reach the target. But having said that, let's go back to these two diseases which I'm referring to. The first disease what I'm referring to is lymphatic filariasis, and the second is regarding the worms in infestation. We call it soil transmitted helminths. So if you recall the previous slide, the geography which I was showing you, reddish structure. Now you can see nearly the same areas in India are having lymphatic filariasis as a big problem. And in this, what happens? It's a mosquito transmitted disease. The mosquito bites an individual who is already having macrofilaria, adult worm in the body, and the larva is picked up by mosquito. Then mosquito, inside the mosquito, the larva matures from stage 1 larva to stage 3 larva. And that stage 3 is the infective larva. And when the mosquito bites some other person, the infective larva goes inside the body. And that microfilariae becomes adult worm, male and female. They live either in the lymphatic channels or in the lymph nodes inside the body. And each adult worm, like they marry basically husband and wife, and they produce babies known as microfilariae, and they can produce up to 50,000 microfilarias per day. That is the power of that particular worm. And usually what happens, these adult worms live for 5 to 15 years in their lifespan. So till the time they are alive, what happens, they keep on moving inside the lymphatic channel or inside the lymph node. And when we see that, through the ultrasound, we find that the movement, it is known as basically, filarial dance movement. Now, when these adult worms die in the sense like after 5 or 15 years, then the local antigen antibody reaction happens in the lymphatic channel, and the lymphatic channel becomes blocked. Then the lymph flow which was going from peripheral to central system, it becomes blocked, and the swelling starts happening. So that is the whole pathology. The interesting part of lymphatic filariasis is that the microfilaria stays inside the lung or lung lymphatics, and they do not come out in the daytime in the peripheral blood. Only during the night time, after say 8 or 9 p.m., they come in the peripheral blood. So if anybody gets blood tested during the daytime, we will not find microfilaria. It is only during the night time we will find the microfilaria. So the national program essentially does night blood slide survey during night time. So that is the story of lymphatic filariasis. And on the right side, we have about the deworming. I'll not speak much on here because you all know that if we, have the contaminated water or food which is having, eggs, they will go inside the intestine, and the adult worm, round worms, develop inside. And the worms eat all the food, what nutrition a person has, and the body actually becomes weak. The interesting part about these diseases is that you can actually see and you can know what this disease is all about. So can you see the picture? Do you find this, lady and the poor man visible to you? Just imagine this is lymphatic filariasis. See the limb of that lady, the left leg is pretty okay, but right one is totally, pathetic. See this man, both the legs are badly, impacted, and you see hydrocele as one of the manifestation. So in filariasis, what happens? One can be lymphedema, which is swelling of body parts. It can be legs, it can be arm, it can be breast, it can be like, around the testis. If that swelling happens, watery fluid, lymphatic fluid collects, that is the hydrocele. Now, this is a position wherein there is no treatment available, either medicine or surgical. Only for hydrocele we can do surgery, but for lymphedema there is no medicine available. That is why we need to focus about prevention, and prevention is very important in this particular case. On the right side, if you see the slide, these are the intestinal worms, round worms, which are in the our intestine. And if you see this picture, this is basically only a 4-year-old child who is basically having so many worms inside the body. So the message what I want to give to all of you is that both these diseases have very nice preventive chemotherapy. Like we have drugs for filariasis, we have DEC, we have albendazole, and recently there is a third drug which has been added, ivermectin. If we use DEC and albendazole for 4 to 5 years in a specific geography, we can eliminate the disease. If we use triple drug therapy, we can eliminate it in 2 to 3 years timeline. On the other hand, for the right side, if everybody of that community consumes albendazole twice a year, we can eliminate this particular disease. So I'll not go into detail, but I'll just let you know that the program for eliminating lymphatic filariasis started in India in 2004, and with DC alone as mass drug administration campaign. And in 2007, it was added by albendazole. So, and the plan was to eliminate in 5 years timeline. But having said that, we are in 2023, and it has been close to like 19 years. India has not been able to eliminate this particular disease. Now, what we are aiming currently is that if everybody consumes in the endemic geography, we will achieve the target. So there is a very high level commitment from the Ministry of Health, wherein they are clubbing the lymphatic filariasis MDA campaign with the NTD, National Deworming Day campaign. And 10th of February and 10th of August are the 2 dates where these 2 campaigns will happen in the country, depending upon the endemicity. For lymphatic filariasis, in 20 states, the endemicity is there. There are 328 districts which are endemic, but out of them, many have actually achieved the target of less than 1 mf in their area, around 133, and rest of the areas are doing MDA or they are doing transmission assessment survey. So this is a very brief and a fast presentation because I want to have some time for discussion. I'll stop here, but please feel free to ask questions if you have. Oh,
I would like to ask all the participants if you have any questions, please unmute yourself and go ahead. Or if you want to drop the questions in the chat box, that's also fine.
or else I will ask questions. How many of participants belong to geography of? I'll show the picture again. Basically, UP, Bihar, Jharkhand. Just a minute. Okay, if you can see the map of India, is it visible, Anshika?
Yes, we can.
Okay, so if you see this geography, those participants who belong to that geography, just either come on video or just put on chat. Am I still there?
Yes, you are very much.
Okay. Quit unexpectedly. Okay, fine. So the reason why I'm saying so is that out of all of you living,
Dr. Tripathi, there might be an issue with your network.
I'm sorry, I was taken off the Zoom. So the reason why I was trying to discuss that picture was that people who are from that geography, how many of them have ever taken medicines, which is DC albendazole or DC albendazole average, or have their family members ever consumed those medicines? That was the primary question. And if nobody belongs to that area, then it's a matter different. So yes, leprosy is definitely high. Fully agree with you, Shatabdi. But let me finish off LF and then we'll come to other NTDs. So is there anybody who has consumed the drugs like more than 2 years? So nobody is showing their presence. So my worry is that many people who are educated enough living in those areas, they do not know that they are living in an endemic area. And mind you, the infection happens usually during the childhood, but the symptoms will start during the adulthood. So people do not know that they are already infected and they will be having symptoms later in the life. So what is the main reason to not progress like China or other countries which have comprehensive elimination program? Is it possible to eliminate by 2030? So thank you, Jaipal, for asking this question. Let me give you a story about lymphatic filariasis elimination in China. So what happened in China, they started with mass drug administration, but they felt it was not going to be successful because the problems were multiple. So what they did the fortification of salt by using DEC. So whatever salt was there, they mixed that with DC, tablets, and the content was mixed, and they went ahead across those geographies for 2 years. And if we do that, everybody consumes DC salt, we can actually eliminate. In India also, we had been discussing about this. ICMR has done a small study in Andaman and Nicobar, where they have demonstrated that by using DC fortified salt, we can eliminate. But the problem is that the whole country is not endemic. We have only like 328, districts out of 766 districts. So how do you segregate those districts? And then how do you ensure that everybody gets that specific salt, which is, fortified one? Because there are so many salt companies in India. So the government program is looking into it, but it is slightly challenging. And second, China is a very sort of, military type of regime that if you are supposed to do something, you will have to do something. But in India, we are democratic. We are providing drugs to individuals and people are not consuming the drugs. So that is one big problem. But still, having said that, there are issues which are beyond these things like sanitary condition, living standards, clean drinking water. All those things also contribute towards improvement. So if those things happen, we do improve. Then Stuti has asked, how do you think that MDA can be increased? Good question. And can we also plan treatment for grade 5 and 7 patients? Are there any other schemes that can be helpful for LF patients? Very good. So how do we improve MDA coverage? So we have multiple things to be done for that. One is from the supply side and second is from the demand side. From the supply side, what happens that we ensure that the micro plants are there where every household is enlisted. Second, we have health workers who actually get trained and they visit each and every household and provide the medicines. Third, we also ensure good supervision and monitoring happens from the health system and partners so that data is very reliable. On the demand side, what happens? People need to be trained or informed well in advance that what is the disease we are trying to eliminate and why these disease drugs are important for you. Because if people do not understand the importance of drugs, they will definitely either not take the drugs or they will take the drugs but will not consume the drugs. So we are doing, like Government of India is doing a lot of efforts now for supply side as well as demand side. Supply side things have improved a lot. Now drugs are available in the households. In the past, what used to happen, MDAs were done by various districts at any point of the time in the year. Somebody will do in January, somebody in February, so and so forth. But now Government of India has announced they will either start on 10th of February or from 10th of August, which is a good thing. Now you will be watching a lot of IC material which is going to come in next 2 to 3 days. Manoj Bajpayee, just like Amitabh Bachchan in polio, Manoj Bajpayee has been invited for being a brand ambassador. So multiple things are there. I will not speak much on that. Social media, Twitter, Facebook, Instagram have to be leveraged. Second, how what plan for treatment of the grade 5 and 7. Now, mind you, it's a very challenging job. Like grade 5 to 7 lymphedema is there is no medicine available. We can only do some sort of antibiotic treatment for secondary bacterial infection or some fungal infection can be taken care by antifungals. But having said that, very recently we got in touch with a group in Kerala who is using Ayurveda, yoga, and modern therapy. It's an integrated approach by using all three mechanisms. And what we found that they have reduced the grades 5 to 7 swelling to a large extent. This institute is known as Institute of Applied Dermatology. It is based in Kasargod, very like near to Mangalore, basically. And we have given them some resources to open such centers in UP and Bihar. Two centers in UP and two in Bihar. And if we find that the things happen here, it will be used by more centers. So department like Ministry of Ayurveda, Ayush is basically looking into it. So we will have some good results in next maybe 1.5 to 2 years timeline. Then are there any other schemes that can be helpful for LF patients? So we are also working with Department of Social Welfare and asking them that if the serious severe grade patients can be provided disability certificates so that some pensions can be given, some social schemes can be provided. So this is what we are aiming at. Then Shatabdi has asked for patients with deformities out of various NTDs, there are availabilities for reconstructive surgery. But the problem is motivating them. How can we? Okay, fine, very good. So for leprosy, it's very important. Like stage 2 and more, if we get grade 2 and more, if we reach, then it requires some sort of rehabilitation and surgery. So it's basically the matter of convincing lies largely on the people who work closely with those families. It can start from ASHA, ANM, medical officer in charges. We can also bring in the Mukhias, Panchayati Raj people, the education department, teachers can be roped in. So if we explain to them how it is being done, and then one more important group is the people who are known as patient survivor network, like those who have struggled and suffered themselves. If we can invite them, if they can, small video clips can be made out of them, and if they can speak, what, I had this problem, I underwent this treatment and how it has helped me. So those type of things can definitely motivate. I'll stop here. I don't have much questions, but let me invite Rajiv sir, because I have not given him time to speak. Rajiv sir, over to you, please. Please come in.
So before that, I would like to introduce him again for the people who just joined in.
Yeah.
So today we have Dr. Rajiv Kumar Jain with us. He's a senior advisor with FPHS on One Health and NTD. He carries experience of near about 40 years in health and hospital administration. Currently, he's serving as the Director Program Academics and Research at Academy of Hospital Administration, AHA, India. And earlier, he was awarded as Fellow Award of Indian Public Health Association, and he has also been the chairman for Occupational Health, Safety and Environment Committee at Delhi Management Association. Along with that, he has also served earlier as chairman of the Health Management and Hospital Management Committee of Delhi Management Association. We would be looking to hear from him about his recent writings and his thoughts on elimination of NTD via a roadmap. Over to you, sir. And before that, I would like to play a video which he requested. Yeah, just a Can everyone see my screen? Yes, I'm starting. Can you hear it as well? Okay.
Sound,
No, Vanshika.
sound is not there.
No,
Yeah.
sound is not there. Just a second. I would like to ask the host or co-host to share it. Just a minute.
Just open the voice. The voice is actually, yeah.
Yes, yes, yes. We are just starting. So just 30 more seconds. Yeah, I can hear it now.
WHO and the global NTD community are working towards one goal, a world free of neglected tropical diseases. The launch of the new NTD roadmap for 2021 to 2030 was a turning point, but a changing funding landscape and unpredictable international context have led to challenges. NTDs continue to disproportionately affect the poorest members of the world community. 16 countries bear 80% of the global NTD burden. However, the number of people requiring NTD interventions has decreased by 25% over the last decade, falling by 80 million people between 2020 and 2021. More than 1 billion people were treated each year between 2016 and 2019, and as of December 2022, 47 countries had eliminated at least one NTD. But COVID-19 took a toll on community-based interventions and on people's ability to access health facilities. As a result, the number of people treated for NTDs fell by 34% between 2019 and 2020, before rebounding again in 2021. In 2022, WHO published 52 guidelines, tools and other information products to help the global NTD community. It continued to evaluate and approve new medicines to treat these debilitating and deadly conditions, working to ensure equity and human rights in NTD interventions. WHO works with countries to help put in place the actions and frameworks that will benefit their people. WHO wants NTD treatments to be sustainable and is working with partners and donors to ensure this, building global collectives and platforms for advocacy. The last few years have been challenging for the global NTD community. Now, we need to reverse the delays and look to the future. We must invest in innovative operations and financing solutions that foster integration and cross-sectoral collaboration. We must boost global support for countries with the highest NTD burdens. And we must continue to facilitate country ownership and the sustainability of NTD programs through new approaches to financing and implementation. Together, we can foster sustainable interventions that will allow us to reach our 2030 goal of a world free of NTDs.
Yeah, over to you, Dr. Jain.
Thank you, Anshika, for the discussion that happened. And thank you, Dr. Bhupendra Tripathi, for setting the tone. And it's really nice to have bottoms-up approach. That is first, our local community, the states which suffer the most, and India. But as you know, neglected tropical diseases require global action, global planning, global strategy with local focused action on the ground. And I feel January 2021 was pivotal in reviewing the progress for the previous 9 years and setting a roadmap for the next 10 years, that is 2021, 2030. And you also mentioned about the roadmap that India also tried to emulate for its own population. So in the last 2 years, a lot happened. And a lot means COVID-19 as well. So let's take stock of the situation for the last 2 years since the launch of the roadmap 2021-2022. Progress has been made. Nevertheless, hindrances towards achieving targets for 2030 have arisen, and work to overcome these obstacles continues. Now, these endeavors have also revealed the scale of the task still facing the global non-tropical, neglected tropical diseases. Of course, disruption as a result of the COVID-19 pandemic has continued to afflict long-standing and new programs alike, while other entrenched issues have reemerged in new and challenging ways. The global neglected tropical disease community is also confronted with a changing multidimensional funding landscape as donors reassess priorities and adapt to new ways of working, as well as a challenging and unpredictable international context. As a result, progress in controlling, eliminating, or eradicating neglected tropical diseases has not been as far-reaching as expected. The burden of neglected tropical disease continues to be unequally borne by a small number of countries. 16 countries bear 80% of this burden. Slower than expected progress in high burden countries, uneven progress across certain of the 20 diseases and disease groups, and persistent underlying risk factors, that is poverty, climate change, and rapid population growth, are all threats to achieving the 2030 targets within the defined timescales. There have, however, been many noteworthy successes which are documented and which require to be shared on this platform today. Over the past decade, the number of people requiring interventions against neglected tropical disease has decreased by 25%, falling by some 80 million people between 2020 and 2021. The burden of disease calculated in disability-adjusted life years is also steadily decreasing. More than 1 billion people were treated every year for 4 consecutive years between 2016 and 19. As of December 2022, 47 countries had eliminated at least one neglected tropical disease. This positive trend was disrupted by the COVID-19 pandemic, however, which severely affected neglected tropical disease programs, leading to reduced implementation of community-based intervention, restricted access to health facility-based services, and severe impacts on the supply chains for health products. Consequently, the number of people treated for neglected tropical diseases decreased by 34% between 2019 and 2020, although a generalized resumption of activities enabled an increase of 11% in 2021. The 21-22 period also saw several outbreaks of neglected tropical diseases, including dengue, chikungunya, leishmaniasis, and scabies, whose management was made more challenging by restrictions on movement. Now we must review the 3 pillars for the 2030 roadmap. And if you recollect, the 3 pillars, as was shown in the video as well, were the programmatic action, operating models and culture to facilitate country ownership, and cross-cutting approaches. This is fundamental to ensuring not only sustainable development goals, but also ensuring that universal health coverage is achieved. Now, in the foundation for people-centric health systems, what are we trying to achieve? We are driving this initiative only through multiple approaches, through research, epidemiological approaches, and evidence-based policy planning and campaigning for ensuring that evidence-based policy gets to be workable on the ground and is reviewed by actually gaining evidence on a timely basis. Programmatic action, that is the first pillar, has been accelerated for the areas identified in the roadmap. Strategic and technical recommendation, that there were 3 meetings of the strategic and technical advisory group for neglected tropical diseases. Normative guidance and tools, that 54 WHO publications released in 2021 and 52 in 2022. Global advocacy, recognition of 30th January as World Neglected Tropical Diseases Day is a remarkable achievement. And that's the reason today FPHS is conducting this webinar. Adoption of Abu Dhabi Declaration on Eradication of Guinea Worm Disease and the Kigali Declaration on Neglected Tropical Disease is also a landmark achievement. Capacity building in terms of launch of the NTD Open WHO channel, as well as in the areas of medicines and other health products, with expanded donations reaching new diseases, that is albendazole for cystic echinococcus, and ensuring more quality assured medicines. For example, 4 pharmaceutical products pre-qualified by WHO in 21 and 2022. Innovation has been fostered to fill existing gaps, with several new medicines under evaluation and 18 target product profiles for diagnostics have been developed. Action has also been taken to address the challenges of antimicrobial resistance and work on gender, equity, and human rights, an area of particular relevance to neglected tropical diseases, has also progressed. In the area of cross-cutting approaches, we have intensified action on the ground. Preventive chemotherapy is being expanded to other diseases such as teniasis, and skin NTD approach is rapidly imposing itself as a powerful resource to address the burden of at least 10 diseases with dermatological manufacturers. Cross-sectoral coordination has also progressed for One Health and WASH, while the global vector control response has been strengthened by the launch of the Global Arbovirus Initiative. Finally, efforts have been made to strengthen the cohesiveness of the monitoring and evaluation processes for NTDs to improve its consistency across all 20 conditions and to boost data visualization through interactive dashboards. So substantive action has occurred on second pillar as well. Now we look at the third pillar of the roadmap from 2021 to 2030. In the last 2 years, action has also been taken to change the operating models and culture to facilitate country ownership. For example, in facilitating the adoption of WHO's sustainability framework by a number of countries. Coordination within the NTD community has been stimulated by the establishment of or expansion of global collectives of NTD partners and platforms for advocacy and information sharing. The need for sustainable financing has also emerged as a key factor in enabling the 2030 roadmap targets to be achieved amidst the turmoil generated by the COVID-19 pandemic. Finally, if I have to say, with what has actually happened, we would say we have been inspired, and we have now seen a resurgence of dedicated public health movement, and also public health and pursuit of health as a fundamental human right, which I feel through the NTD approach has been again come to the center stage. And India is also leading the movement in this sphere. Now, in our pursuit for the Roadmap 2030 targets, we need to reverse the delays to progress and ensure that past gains are not lost. We must invest in innovative operations and financing solutions that foster integration and cross-sectoral collaboration. We must boost global support for countries with the highest NTD burdens and continue to facilitate country ownership and sustainability of NTD programs through new approaches to financing and implementation. So time is of the essence as we work together. Sustainable Development Goal 3.3 and end the pandemic of NTDs by 2030. So we have 7 years to go. 2 years have passed. We must accelerate our actions. And Dr. Bhupendra Tripathi is one of the partners in helping the states in accelerating this progress in the next 7 years. And we hope that by the end of 7 years, all these states will be self-reliant. They will be financing from their own resources. They will not be dependent on external resources, not only resources in terms of financing, but also in terms of planning and program implementation, so that when new entities arrive, they are also equally prepared. So there is a linkage here between One Health and the NTD. And it's also important today that India is also celebrating its World Leprosy Day, because our father of the nation lost his life today, and he had worked his life throughout his life for leprosy care. So it is not a coincidence. It's a proud moment that January 30 is not only celebrated as the World NTD Day, but also as World Leprosy Day in India, when the father of the nation laid down his life. So at this juncture, I would like to stop at this point so that more discussion could happen later. Yeah.
Thank you for sharing your insights, Dr. Jain. I would like to ask the participants, if you have any questions, please unmute yourself. We'll wait for a minute. And if you want some more time, you can definitely write them out in the chat box, and we'll take them towards the end. Any comments, suggestions, questions? Okay, if there isn't any, we'll move on. You'll get a chance to speak to Dr. Jain towards the end. So we also have today as our last speaker, Ms. Sindhuja Khajuria. She heads the communication at FPHS. Ms. Sindhuja is a communications lead and expert at FPHS, and she specializes in social behavior change communications to promote well-being and improve quality of life of the marginalized community. She emphasized more on the needs of communication in the public health, on how to reduce the burden. And today she'll be talking to us about the importance and the need of the health communication in the sector, which can help in eradication of LF, leprosy, and other entities in the country. Over to you, Sindhuja. You are on mute.
Okay. Thank you so much, Anshika, and a very good afternoon to all the participants. And I thank FPHS for this opportunity, for me to share my, learnings over my, 13 years of experience in this field. So, health communications is really crucial, especially in driving the public health agenda. And today, when we are talking about NTDs, it's, we cannot underscore the importance. It is really an important intervention. Like now we have actually reached a stage where communications cannot be just a support function, it has to be an important public health intervention, apart from other problematic interventions, to reach out to the communities that we are targeting, to drive better health outcomes. So today I will discuss, why communication interventions are integral and, what we can do to drive behavior change, address stigma and discrimination, impact the care-seeking behavior and treatment outcomes. But before I proceed further, I want to ask all of you a question. Like, what if a stranger knocks on your door and offers you a pill? Or maybe, for example, if you live in a, endemic area and you see a poster that, okay, you have to take so and so medicine to prevent, NTDs. Are you going to take it?
It will be very difficult to accept it unless until we know in detail, even for educated people, it will be very difficult.
Sorry, you're not audible.
Yeah. It will be very difficult to accept suddenly if someone come and told, unless until we have been communicated well before that.
Exactly. That is why communications is very important, because the awareness about a disease or our risk perceptions, we cannot just suddenly, like, if somebody tells us that, okay, this is what we have to do, and we'll adopt that behavior even if it is for our benefit. So this is where communications has a critical and integral role to play, and I'm talking about especially in context to the mass drug administration program of the government. People living in the poorest communities of the country are given medicines to treat and prevent chronic infections known as NTDs. But, we've seen that public participation in MDAs, they continue to fall short, which is driven by, low disease awareness and risk perceptions among the general public. So in 2014, Ministry of Health and Family Welfare, they launched this campaign called Hathi Mukt Pav Bharat, Hathi Pav Mukt Bharat, under which IC materials were prepared. And one video that really resonated with the public, I would request Anshika to please play it, and then we'll talk about it.
Yeah, sure, Sindhuja.
Yeah. Anshika, its sound is not there.
Yeah, just a second. Yeah, we are just replaying it from the start.
संकेतानि प्रदर्शयन्ति ज्ञानमार्गम् संकेतानि प्रदर्शयन्ति ज्ञानमार्गम् संकेतानि प्रदर्शयन्ति ज्ञानमार्गम् संकेतानि प्रदर्शयन्ति ज्ञानमार्गम् ज्ञानमार्गेण जनिष्यन्ति सत्यप्रमाणम् ज्ञानमार्गेण जनिष्यन्ति सत्यप्रमाणम् सत्यप्रमाणम्
मैंने बोला था ना पूरे गांव को ले आऊंगा। नमस्ते।
हाथी पांव। आज भी भारत में 50 करोड़ से ज्यादा लोगों को हाथी पांव होने का खतरा है।
ये किसी को भी कभी भी
पूरे गांव को ले आऊंगा।
मैंने कहाँ सोचा था कि ये
नमस्ते।
मगर पता है, बस एक खुराक हर साल आपको इस बीमारी से सुरक्षित रख सकती है। बस एक खुराक जो बिल्कुल सुरक्षित और मुफ्त है। साल में एक बार खाएं। हाथी पांव मुक्त भारत के लिए आइए हम सब मिलकर भारत से हाथी पांव का निशान मिटाते हैं।
Yeah. Thank you so much, Anshika. So the reason, I wanted to show you all this video is to just reiterate, the importance of communications. You've seen how, a group of children led community to an unexpected source of like education and inspiration for LF preventions. People could relate to because, people from the community itself joined together, like, to deliver a message. And message is so simple, like pills are free and safe, and everyone, if they work together and consume their dose, India can eliminate LF. So it's evident, that people's participation is actually becoming the central issue of our time, and people's participation requires communication. If we have to reach out to people and, talk about positive behaviors, we have to communicate to them in the way they understand the message clearly. So, everybody coming together, I would say when we design communication strategies, it's not just the prerogative of people who are, working in the communications domain, but everybody in the public health. Like you need all hands on the deck, like everybody to come together, the scientific community. And it's very important to resonate with people, by giving them a platform, like the communities, they need to be the central like a figure in telling of their own stories. And how do we do that? We need more interventions like formative research, which gives us insights into what people want, what drives their health seeking behavior, how can we impact the treatment outcomes. So all of this when put together, like, it can help in raising awareness about NTDs, about actually addressing the stigma and discrimination that is associated. We can involve the communities in the development agenda, bring NTDs to the forefront of public health discourse. And by doing all of this, all these interventions, they can help in improving access to care, increase acceptance and understanding of NTDs, and it can lead to better health outcomes. So, my only takeaway is like communication should be, an important intervention right from the beginning of the programmatic intervention. It should not be just like, at the end of your initiative, we are just like coming up with few reports to talk about what was the impact of the intervention, or coming up with IC materials to, deliver our messages without going into the nitty-gritties of, what are the communication mediums that we are using, whether we are reaching out to our audience, in a particular region, whether our strategies will be accepted by people we are reaching out to. Just giving you an example, this is not in context with NTDs, but I was handling the communications for Red Ribbon Express, where the objective was to create awareness on HIV/AIDS and, how to reduce stigma and discrimination associated with it, how to, safeguard yourself. So we actually used, traditional theater form to deliver our messages across India. But when we reached the state of Haryana, we actually got a lot of backlash, and we could not actually, the theater group could not perform there in Haryana because, talking about sex is a taboo in that patriarchal society. But down south, that, thing worked absolutely fine. So I think it's very important to understand where we are reaching out to, what are our audience's perception, what is their level of knowledge when we are designing the communication strategies, and working together in collaboration with the scientific community, to demystify the technical messages, how to make it more simple. These are some of the, finer nuances we have to look into, understanding the local context of where we are operating. So I think all of this, like put together can help us in actually accelerating the efforts towards the elimination of NTDs. This is just very briefly that I've touched upon, why communications is important. And there needs to be a lot more to be done, because what happens is generally we, for the sake of putting a tick mark that, okay, we have to come up with XYZ number of communication products to increase awareness, but we forget that, let us also involve the communities who we are reaching out to. For example, MDAs, how do we actually increase the uptake of medicines or promote the health-seeking behavior? It's only when we understand, what is their knowledge level, what are the risk perceptions, what do they understand, are they aware of their risk factors? So these are some of the important questions that we need to ask, and ensure that communications is integral to our programmatic interventions and not just one ad hoc activity at the end of the day. So with this, I would end my session, and if people have questions, please free to ask.
So Sindhuja, there are a couple of insights, and there was a question as well in the starting of your conversation. So Jaypal is asking if SBCC is very important, and can we also link it with the data?
Yeah, absolutely. As I mentioned, it's very important, that our messaging is based on the evidence, and data is important because we just can't, come up with general messages. For example, we have to contextualize to where we are actually operating, what is the data there, how can we integrate the outcomes of, for example, a scientific paper or the key findings into our messaging to align it, with our strategies or programmatic intervention. So data is the key, definitely. Yes, but as communications professionals, our objective should be how do we simplify the technical findings, the evidence, how do we package our communication products, our, draft our messages so that people who we are reaching out to, they understand it without like complicating it further.
Yeah. So guys, any more questions, clarifications, insights? We have Dr. Jain, we have Sindhuja as well. If not, then we have a couple of announcements to make. So we'll be sharing a video on cervical cancer on our YouTube channel today, or maybe tomorrow. So here is the link of our YouTube channel. Please go and subscribe it. There's a lot more information, as Sindhuja rightly mentioned, about SPCC, and presenting information in not so complicated manner. We'll be talking about cervical cancer, the risk factors, what are the preventions, cures, and what can be done moving forward in the particular video. Do drop in your email IDs in the chat box. We will be sharing a participation certificate with all of you. Yes, looking forward for it. And I'm also sharing a feedback link. Do fill it to help us understand where we can improve, what can be done better, and where were we lacking. And it'll be great to see you all if you can come on camera for a minute or two, and then we'll be wrapping up the webinar in a few minutes. Would request any of my team members to take a screenshot. In the meantime, I'm just getting the Google link.
And do
I don't
visit
want-
the monuments today. All will be purple lighted. If you go to New
Yeah.
Delhi station, that will be purple.
Thank you for the insightful information, sir. Should I call people by the name so that they can come on the camera? We are waiting, guys. Dr. Preeti, Dr. Mahira, Dr. Jitesh, Divya is still connecting, Riddhi,
Dr.
Vinod,
Damodaran is also there, Dr. B. Damodaran.
yes. Dr. Basant is there as well.
Why reluctant to show the faces? You don't like your faces?
No, we want to see everyone so that we know whom we are talking to rather than just seeing the names.
Yeah.
Okay, perfect. So I'm taking the screenshot. I did. Here is the link for the feedback form in the chat box. Please go and fill it. So we are 34 minus the team members. So when I'll get 20 responses, we'll close the session. So everyone needs to fill it. Can we access the Google form? I'm sharing the stats here so that once I get near about 10:20, we'll close. Perfect. We are getting a lot of responses. Hurry up, guys. It'll take just 45 seconds of your time. It's just a checkbox. We are halfway through. 10 more. We are 32 in number.
Yeah, I did give my response, and thanks to the entire team, and thanks to the Jain sir. We generally we meet frequently, and thanks to Tripathi, and thanks for narrating a very good session. Thanks to all. Thank you.
Thank you. Bye. Have a good day. Guys, 8 more responses, please. FPHS team members can also fill. We'll have our internal feedback. $13. 2 more.
In fact, Dr. Bhupendra, in the morning, when I shared this webinar link. Dr. Prakash Couture, who we are working Kasaragod, Kerala, he was mentioning the interaction with integrative medicine for familial lymphedema. This is the way we show light to the world, actually.
Absolutely. Absolutely.
Innovation and finding solutions where no solutions exist. And nothing could be better than locally generated knowledge system integrated into the existing knowledge systems. I think that's the wonderful lesson that we get through NTD as we operate in our local communities.
Very true, sir. Very true. And that is the reason why we are trying to support IED in scaling up their model.
Yeah.
So we are aiming to provide 8 centers supported by Gates Foundation, and we are in touch with the Secretary Ayush and the Minister Ayush, wherein they can also scale it up across all the medical colleges, Ayurvedic medical colleges in the country.
Great.
Because
That will open